events. So we both welcome you all and to the committee members for coming through, which we think is going to be very informative and hopefully have some good outcomes to help change the dynamics and help serve the community and patients and making sure that transport services are provided in an expeditious way, but also in a quality way as well. With that, I'm going to have the clerk go ahead and call roll.
Senator Douglas.
Here.
Senator Storm. Senator Webb. Representative Hart.
Here.
Representative Meredith.
Yes, sir.
Representative Wilner.
Present.
Senator Givens.
Present in the room.
Chair Fleming.
Present in the room. And we definitely have quorum. I'm going to make some open comments. Then I'll ask Co-Chair Senator Givens to make some open comments as well. And then we'll go ahead and get into the meat and the heart of the agenda, which we have, and y'all should have the access to that on the website as well as the presentation from both our presenters today. First of all, House Bill 77 was a heck of a process, but it came out with a good result. And I think it's a tribute to the individuals in the General Assembly, but probably more important to the stakeholders of you all out there in the audience to make this come to fruition. We really are anticipating having some good discussions. The first meeting today is going to be more of a foundational to set the framework to have an understanding of how different things work. So this will serve as a foundation for us to go forward in terms of providing some good recommendations at the end of the road, in which we will hope to in turn these recommendations into bills so it can change some of the dynamics of going on with the EMS in a very positive way. I want to also express my appreciation to you all as well as to the members on the committee, that your information on your priorities and what you think are important was received. Senator Givens and I have gone through those priorities. We didn't rank them, but we just put them down. I want to try to cover as many as possible as we can over the next several months. So I do appreciate y'all's participation in providing that. As I mentioned, this is more of an information gathering. We're going to try to get as much information as we can as possible from various aspects of the EMS community. Hopefully turn this into some bills, and like I said, change some things how we're doing things in the EMS environment. I want to stress that, which we did during the discussions with House Bill 777, it's at least in my mind, it's primary that we keep the patient, the citizens of the Commonwealth in our mind and foremost in our mind, because that's what we're here to do. That's what we're getting paid to do. That's what a lot of y'all get paid to do. I know if you're in the private or public sector, to make sure we provide that service in the best possible way, and also the highest quality as well. I just want to just go over just a couple of themes that came out of the requests of some emails that y'all sent. Some of those themes, and I think probably the main one is workforce. And from an education standpoint, looking at the pipeline of that, the attraction and retention of individuals that will come into the field. Certificate of need is another issue. Another is behavioral transportations and how to handle that. And also inter-facility transports, and also reimbursements. That seems to be a lot of hang-up across the board when it comes to health service in general. So with that, like I said, I will look for a really, really good, robust conversation that we'll be able to go through and decipher and come up with some good information so we can take a proactive, positive actions in the next upcoming session. So with that, I'm going to ask Senator Givens to make some opening comments.
Co-Chair Fleming, thank you, and well spoken. I think I'll echo everything that you had to say, and I'll add a few brief words. I'm excited about the opportunity the next few months to work with each of you as stakeholders and investors in this process that provides such vital care to our citizens. One of the comments that those that have worked in health policy with me before know that I've made, and I'll make again here because it's fitting for this space as it is so many others. Someone much wiser than myself said some years ago, as it relates to the medical delivery model in the United States of America, that if we could blow the whole thing up and start over again and do it differently, wow, we'd have a great chance to do it in a much more efficient, effective way. But we can't do that because we have with us the luggage we've carried all our lives. We're going to carry that on forward. So I share that with you to say, over the course of the next few months, as you hear us engage in challenging questions that may feel like they're threatening to your turf, try to set aside those personal interests. Let's all engage in this conversation and see if we can recreate something built upon what we already have to deliver better for our citizens and our taxpayers and the people that we love and want to care for. And so with that, I look forward to the conversation. Almost all of you should know how to reach me. Certainly reach out to me between meetings if you have ideas or thoughts. I welcome that input. And Co-Chair Fleming, I look forward to today's discussion.
Thank you, Senator Givens. And I just wanted to underline what the Senator said, that we are here and we're here to serve you all and to make sure that your information and your comments are here. So you can contact any one of us on this committee. Like I said, we want to make sure we get the best possible product after through going through this process. With that, Mr. Sloan, if you wouldn't mind making yourself available up to the table. You're the interim director, and I appreciate you coming on board in the interim. I know you've come in a transitional period, and I've gone through quite a few of those, and it's not easy to go through and take an inventory of things and see where we are and try to abide by the new laws that we just passed recently. So thank you very much for stepping up and helping out. So we look forward to hearing from you. And go ahead, if you don't mind, introduce yourself, and please proceed. Just a little closer to you.
All right, there we go. All right, again, my name is Eddie Sloan. I'm the interim executive director for about 5 or 6 days now. But thank you for the opportunity today. I think what you were looking for is a kind of a broad overview of EMS in the state of Kentucky, and maybe find out a little about our education system and personnel and how EMS is run in the state. In the interest of time, a few of these slides I'll kind of jump over, but we made it quite lengthy so that you would have the information later if you come back and look at the PowerPoint in a handout or such. But we'll talk a little about the service models, the classifications, which will be key going forward as we look at the new regulations and how to make sure that each of the classes are met and the folks end up in the services end up in the right classification and able to make they're not restricted on the runs they need to do. The diverse regions in the state of Kentucky and the ALS versus the BLS model, just to make sure that everyone is pretty clear on what each of those mean. There are 221 services in the state. They go under 7 classifications, but only 4 classifications are ground ambulance. And in reality, there's only the largest class is a class 1, and that's what we think about as a traditional service. There's 182 class 1 ground ambulance services in the state, and those are the services that respond to the scene. They're the least restricted. It's what we think about whether it be emergent or non-emergent 911 calls. Those are the services that go to your house, go to the hospital. They can make interfacility transfers. Most in the state operate at an advanced level or with paramedics, but they can also, and there are some remaining, basic life support agencies in the state of Kentucky. Again, they can make interfacility transfers. They're not restricted in that manner. The Class 2 agencies are BLS only. There's 4 services in the entire state, 2% of the folks we license. It's BLS only, and they cannot respond to a house to pick someone up or take them someplace. They'll be doing non-emergent runs, and they're not part of the 911 system. Class 3 services, they're specialty care services, and they're typically, and in fact, they're always interfacility units. They're into 3 subclasses: adult critical care, pediatric critical care, and neonatal. And that's where we start thinking about Norton's or UK or agencies such that are making the the higher, we'll say, the more acute care patient in between facilities. And again, a really good model of that would be the University of Kentucky and the Baby Buggy or Norton's. There's 11 services licensed in Kentucky, but with that being said, there's probably 3 or 4 that are based outside of Kentucky. For example, Vanderbilt has a unit that will come into Kentucky, and so they are licensed in Kentucky. So it's a pretty small number that resides within Kentucky. We're probably talking about 7 or 8. And they're somewhat of an extension of the ICU or the ER. Again, we're talking about patients that perhaps are on ventilators, though a ground one may also do ventilators, but it's those that are more equipped to take them on a normal basis, pre-acute patients. Class 4, again, we're talking about 7 services, and those are restricted to the confines of an area. And the best example, so you think about who we're talking about, may be the Bluegrass Army Depot. So at the Bluegrass Army Depot, they've got their own ambulance service. They stay on the depot. They'll respond to calls on the depot, but the only time they'll ever leave the depot besides transporting a patient is maybe Madison County has to use them for mutual aid response. But we're looking at 7 services, and it's pretty isolated. Just for your later viewing, there are the rest of the classes, which include aeromedicals and special event type license that we issue. As we look at the service models in the state, the majority of them are community, nonprofit, non-fire. That would be your county ambulance service or ran by a board in a county. We have 54 services that are affiliated in some way. They're a transport ambulance service, but they're affiliated with fire departments. 22 services that are affiliated with a hospital. The hospital runs the ambulance service through an agreement or through having the license themselves, and that those should not be confused with the type 3s that we were talking about before. There are some hospitals that, in fact, run the service. And then we have 56 private non-hospital. And that number may be I think that number is a bit deceiving. I would only point out that those are licenses that are issued. So you may have a private company that's in 5 or 6 or 7 jurisdictions, and that would be 5, 6, or 7 different licenses. So the reality of it is those private non-hospital is more likely to be made up of 11 or 12 different companies and not 56 different companies. There was a request that we talk a little about the rural EMS in comparison to maybe the models that we see in Lexington, Louisville, and Northern Kentucky. And I think it's important that, as you well know, we're a pretty diverse state, and many counties can only support a single agency. So when we think about Lexington, there's 2 Class 1 services in Lexington. In the Louisville area, there are several. And as we look in the Northern Kentucky, I think it's 31 services. I think they're just in the 3 counties. But when you get outside of that, most counties can only support a single agency. Most of those, as we saw earlier, are county or municipal based. The geography plays a key role in what's happening. I think that's pretty obvious to all, but when we think about, there may be 1 or 2 ambulances in a county to cover that entire county, and we think about the terrain and the geographic locations, unlike perhaps that when we think about our urban areas, it's just not feasible or possible to position those ambulances throughout the county so that a response time is 4 or 5 minutes that we may think about in Lexington or Louisville. With that same thing, when you think about turning those calls around, if you go way out into the county and perhaps don't have your own hospital and you've got to go 1 or 2 counties over to deliver that patient, it's not uncommon from the time the call begins, 911 rings, until that ambulance is back available for service to cover a 2.5 to 3 hour period on a non-inter facility, on a simple, what I would consider a simple EMS run. It's not unrealistic at all. During peak hours, some counties will only have one ambulance in service because that's all they can afford or that's all they can staff or all the local market will hold or support. So if that ambulance goes out, they rely on call teams. They will call staff back or rely on mutual aid from a county that's next to them. Mutual aid's required and it's quite common. I spoke to someone on the phone just this morning talking about a mutual aid situation they'd had 2 days ago. But that's not isolated at all. There are counties that are probably utilizing or at least we'll say putting on standby, maybe not using the mutual aid, but at least raising the ready flag on a daily basis. Agencies certainly struggle to recruit, retain, and compensate their personnel. As you look across the state, and part of my role also includes going out and doing inspections. So that's one thing I do see. Over the past 4 years of those 180 or 200 and some services, I've probably been to 200 of them and met the folks that are working at those 200 services and hear about their problems and the struggles that they're having to get people. And it's not uncommon to hear of a paramedic who's starting out at $14 an hour in some of the rural areas. And so it's certainly hard to keep those personnel and recruit them and to get them trained. And I think it's important to remember that EMS is not a legislative essential. All right. So if a county determines that they're not going to run an ambulance service, or a city determines they're not going to run an ambulance service, or if one of the private services that are operating in a county decides that they don't want to operate today, it's as simple as calling us in the morning and saying, we're out of business. And it's left up for them to scramble. And in fact, that happened 2 weeks ago. An agency called up 8 o'clock in the morning and said, as of 7 o'clock this morning, we're surrendering our license. And fortunately, there was a second company in the same area, but with little or no notice, they had to begin recruiting more people to get more vehicles on the road. Speaking of, so we've spoke a bit of ALS and BLS, and when we talk about BLS, we're talking about our EMTs that you will see in later numbers. And the EMTs manage basic airway at a basic level. They utilize an automated defibrillator. They splint, immobilize, stop the bleeding. And there's a limited range of medications that they can give, some epinephrine for like anaphylaxis and some breathing treatments, but it's a relatively small scope of medication that they give. The advanced life support, that's more when we're typically talking about our paramedics, and they can provide both basic and advanced life support, obviously not restricted, but advanced airway when we think about the intubation, cardiac monitoring and intervention. So with that, they have the ability to recognize the rhythms, treat the rhythms, and they have a really wide range of emergency medications that they can give to treat conditions. And that's really underselling both the basic and advanced. Of course, the advanced does much more. It's, we think of anything from a surgical crike to decompressing a chest. So I'm really selling them short there, but it's broad what the ALS can do. Regional wise, for inspection purposes only, we've copied the Kentucky Health Departments and their regions, but it's really just for regional only. As we pull data, we have the ability to pull down on certain counties or spots that we're trying to get data, but we really don't use, it's a state abroad. And sometimes I think we need to remember that whatever's going on in Pikeville are the same regulations that are going on in Paducah and the same that are going on in Covington. And for the most part, it's a one-size-fit-all once the regulations are applied, and we're a pretty diverse state. Across the state, there's about 1,135 ambulances. Each year, every ambulance is inspected, and it must undergo an inspection beforehand before it can be put on the road. So you're looking someplace between 1,100 and 1,200 ambulances spread across 120 counties. FYI, they're about two to 3 years out in ordering some ambulances right now because supply chain issues. So again, I have the luxury. It's a pleasure to go around and talk to agencies on a daily basis. So we'd love to replace this truck, but we're 18 months and we're getting a demo, or we're doing this, and we're going to remount this truck. So your fleet across the state, I would say, is a bit more aged than your providers would prefer, but they're no different than anyone else. They're restricted by supply chain. Our training and educational institutes, there are 5 different levels of training of certifications or TEIs. So as you can see, the majority of our agencies are a level 3 TEI and also the ability to do continuing ed. So each of those are somewhat self-explanatory, but they go up as to the level that you can teach, or that you can teach within your facility, within your license, and each of those are licensed on their own. So for example, if you talk about the Frankfurt Fire and EMS, they have a license to operate their ambulance service. They have a second license, more so to keep track of them as we look at their TEI. Most everyone wants to be able to especially do their continuing education, and those are licensed and they're reviewed every 2 years. They have a list of equipment that they must have to be the TEI, and a few other processes they must go through. For 2021, to give you some insight as to what the TEIs were doing, EMT, it's that basic level that we talked about before. There were 132 initial courses, 22 AMTs, and 14 of the paramedic classes. I would like to go on that just a bit to provide you some of the insight when I'm out and talking to, especially on the EMT courses. It's not the number of EMT courses that the providers are telling me. Perhaps you hear something else. The providers for me on the EMT courses, they can't get people to fill the classes. They'll put a class together and they're paying for the class. They will put the employee on the payroll to go to the class, and they still can't get enough people to fill their classes. So back to our recruitment. As we go down the line, I'll skip to the paramedic initial courses. There were 14 initial paramedic courses in the state. And as we were speaking earlier today, we're going to put that number someplace around probably about 120 paramedics that we turn out each year, give or take 10 or so. So each county, if we were to break that out, gets one paramedic per year coming out of classes at the rate that classes are available today. This map, you'll maybe look at it a little bit more later, but it shows the TEIs. I would like to point out on this map that because you have a TEI, doesn't keep you from doing a satellite program. So as I was speaking to using, for example, Somerset or Owensboro that are with the community college system, I know for sure that they each do classes. Perhaps Somerset goes to Russell County and completes classes, but the TEI itself is out of Pulaski County. This is probably, I think, more what most of you want to see, and this is the location of the paramedic. Now, the thumb tabs are different colors, but that's because they have the ability to teach multiple level of classes. But when each of those would represent a paramedic program or that has the ability to teach a paramedic program. I would also like to add, I don't think there's a slide, there may be a slide, but just in case, when you talk about those paramedic programs, to complete a paramedic program, you're talking someplace around 1,500 hours. It's about 750 hours of classroom. Along the way, there's about 250 hours of clinicals that the student goes to. Maybe it may be doing blood draws in the hospital, going to OB, to watch the delivery process. It may be going to the ICU just to watch the juggling of medications. They'll do about 250 hours of that while in the class. Once completing the class, They'll do a ride time or internship, whichever term you, and so that's about another 500 hours that the student will take. And in doing so, it's not just the 500 hours. They'll have to see so many and do so many procedures and see so many types of patients. It may be that they have to have, 10 stroke patients, 10 cardiac patients. So it could be more than 500 hours, but those thresholds are on there. So 1,500 hours, pretty intensive training program, and in that 750, it's no cakewalk. If they're spending 750 hours in class, I think it's really fair to say that it's collegiate level class and upper level collegiate level classes for most of it, that they're putting in quite a bit of time out of class. On the educator requirements, better reading for later, and I'm going to jump through these and just 1 second. I'm getting a little lag in the there. I think this is a better summary. The other, I think, would be great for you to read through and think about it a bit more, but in lieu of reading it to you, the educator must be trained to the level they're instructing. That doesn't mean an EMT maybe couldn't train on basic airway, but you have to be trained in the subject that you're teaching. If you're part of a teaching institute for like a level 4, you're looking at a class of about 40 hours for adult education to be able to teach those. So I may be a paramedic, but I can't just go in and start teaching today in a TEI. I'll have to make sure that I've had training in adult education, be able to do my presentation and be able to formulate the class, get together a lesson plan and such. But for CE, continuing education hours, that's a bit different. That can be if I've become an instructor in advanced cardiac life support, if I'm a state fire rescue instructor, then I can do continuing education, but I can't be necessarily a part of the TEI to teach a paramedic class. After doing so, if the student comes along under that way of being an instructor, they'll have to have 5 teach-back classes that they're with other instructors to make sure that they're qualified to be an instructor, kind of much like the ride time or internship that we talked about earlier. There's that sort of internship. They have to instruct 4 hours in a 2-year renewal period. So once they achieve that, it's relatively easy to keep that. Across the state, currently, this is the certifications. We have over 9,000 EMTs, 400 AMTs, 4,200 paramedics. But the next, let's see, I want to go one slide forward, then we'll go back a slide. I think what's really important, though, is we look at those numbers, compare them next to one another. So we have 9,300 EMTs that we've licensed in the state of Kentucky as of the data sometime this week. Having said that, when we pulled the same EMTs to see how many of them were affiliated with services, we only have about 3,600 people in the workforce or they're affiliated with someone. So we've got 6,000 people that have chose to either not work in this line of work, move on to something else. I can't tell you why they're not there for sure. I can tell you that they're not. The same being true when we look at the paramedics. Again, it sounds like a much better number at 4,200, but there's 2,857 that are somewhat affiliated in the state. And I would tell you that many of those are on 2 or 3 different rosters. So it's not unusual perhaps for Anderson County to have someone on Mercer counties and Mercer to have someone on Bull. And so those 2,857 are working at a multitude of agencies to make this EMS system in the state work currently. To make those numbers a bit more grim, I reached out to just one agency, being Chief Bramlage this morning at Lexington. I said, Chief, how many do you have on your roster? They've got about 300 paramedics, okay? Because they have the resources, they've taken the time. Kudos to them for developing a system that they're able to put that many paramedics through. But here's what that does to the numbers. It's not hard to remember. Now there's 2,500 people that are not serving, that left to serve the rest. Take in your Louisville area, take in your northern Kentucky area, this triangle kind of in between. And it's not uncommon. I'm going to fall back. We can check facts if we need to, but it's not uncommon for me to go south of central Kentucky, and they have 1 or 2 paramedics on the roster. In fact, spoke to someone in this room earlier. They're working 36-hour shifts just to make the schedule work. And it gets, the further you get from this region, the worse it gets. And that's my experience of talking to providers or agencies across the state. Going back one slide, I think this will show you a trend as to somewhat to the certifications over for each of the agencies over how we're licensing over the last few years. There was a bump in 2020, and that can be as part of the emergency orders during it was easier for someone that maybe gave up their paramedic or their EMT to come back. Unfortunately, I think I'm seeing, I don't have the data today to tell you that it's for sure, but I think I'm seeing, as you'll see, we had that bump. So we had those licenses go back up, but many of those folks got it back almost as a novelty reason and never really went back into the workforce. There were some, but many seems to be the case. With that being said, I would be happy to answer any questions, gather any new information. I would like to give the one disclaimer that we tried our best to make the data as accurate as possible. In no way do I think we manipulate the data, but sometimes it's just hard to pull it together and put it in a format that's usable and that we can understand. But I really think we've drilled down the data to give you pretty accurate information.
And that's very much appreciated, Mr. Sloan. We know you're only been there for a couple days, and I know, but you're familiar with the profession and so forth. So I know it was hard, but we sincerely appreciate pulling the number of these numbers. And being a somewhat of a data geek, I would like to request something from you. You provide a lot of good information in various categories and so forth, and help me out. And it comes back from my crazy business background. Can you provide a matrix that will have the service, the class, number of providers in the region, as well as where, when I say region, where the education centers are, as well as where the providers are? That will give, I think, myself and the committee members exactly an understanding of how things are laid out in terms of where the weaknesses are, because we're hearing on quite a few occasions like East Kentucky doesn't have X, Y, and Z. Well, why is that? Or is it an accessibility standpoint? Is it just a workforce standpoint? Those sorts of things sort of go through my mind. So if you have a matrix, I can get a pretty good picture of how things shake out in terms of the Commonwealth. So I know it may take a little bit of time. It won't be an easy task. Putting those matrices and spreadsheets together is not easy, but I think it'll really give a good picture of where things are. So I would appreciate that if you could do that. You mentioned in one of your slides, I think it's on 30, which sort of struck me, and that was where the providers. My understanding, if I'm looking this correctly, 33% are working, even though you have 90 or 9,300 that actually are licensed. That's a pretty low workforce given that licensing out there. Now paramedics is around 66%. It looks like to me. That's good. Can you explain why that dynamic is there? I know you said that you can't get people to fill into these positions, but the people are there. Are they even because of pay? Is it the conditions? Could you expand on that a little bit?
Well, what I would expand on would be somewhat hearsay, and it's simply by talking to the services. Can I give you an answer that I can go back and hang my hat on and say, this is my opinion, what I see, I can do that. But, when I talk to providers or services, I don't think EMS has probably ever been a harder job. So I've been at this for a while, and when I came on, I could paint a picture of what this call looked like, and I could submit my run report, and I submitted it in paper, by the way, and it was all good. And so when you look at providers now, the work that they have to do to tiptoe around, to create buzzwords, to get this call, this run sheet through so that the agency can get reimbursed. We could, it's a multitude of problems. We can talk about the difficulty. When I started in this line of work, we could go out, get the patient, take them to the hospital. We were pretty much done. Life's more difficult in that way. It's a harder job in just the interagency, getting people from, I could probably be on board in a week or 2 or 3 days when I started. The onboarding process is long. People tell me they have a hard time that a potential recruit may come in today and say, I'm really interested in this job. But if they walk out that door, they lose them. That person doesn't follow through. And so those recruitment efforts aren't quite as strong as they are. Unfortunately, perhaps there's a process they go through. The pay, I'm sorry.
And I want to put words in your mouth. Mr. Sloan, are you referring to more of a bureaucracy process? You know, the heart is there by the individual who wants to serve. But once they go through that, well, we got to fill out this, we got to fill out that. Then you have the dynamics between the different facilities. I'm just trying to.
No, I don't think that's. I think that many of the providers think, quite frankly, and when you look at the many of the services, rather, when you look at the pay that's offered, the benefits that are offered, that many of the employees they're trying to recruit aren't the employees that follow through, that are willing to put in perhaps the week of. I don't think that perhaps that's too much, not that's too much red tape, but they just simply don't follow through. It's pretty astounding the number of people that'll go through an EMT class that never tests for boards, or never go to they'll go through the entire class. It's 120 or so hours. They never even take the test. And so I don't know if it's that part of the workforce that it's applying, but I think it goes much broader. I think you've got to look at, it's a hard job. It's a dirty job. And it's a low-paying job.
Okay, I'm going to ask 2 more questions. I'll open up to the committee. What do you see, given the provider layout there on their slide? Where are you anticipating the need's going to be in terms of provider?
Oh, absolutely, paramedic.
Okay.
Is that the question you're asking?
Yes, sir.
Oh, I mean, it was paramedic, and it was paramedic 5 years ago.
Okay.
I mean, it's gotten worse. Unfortunately, the of no fault, but the emergency regulations really somewhat hid the provider problem that we're able to skirt around them a bit. But recently in regulations, for example, there's change in regulation that will allow. Before you had to have 25%. If you were an ALS service, 25. If you had 4 ambulances, 1 had to be an ALS provider. That cannot be met in all services now. Our new requirement is you have to have an ALS provider. That's it, because it can't be met 24/7, and we're way behind.
All right, thank you. I'm going to wait on my questions. I'm going to ask Representative Meredith.
Thank you, Mr. Chairman, and I've got a few questions, if that's okay.
Yes, sir. Go right ahead.
One, has there been a study or a survey done of services across the state based on pay rates, average pay rates for EMTs, advanced EMTs, paramedics, within all the different license types?
I can't answer. I simply don't know the answer. I do not know of a comprehensive. There may be regional, but I don't know that there's been a comprehensive county to county, and to what, if so, to what level of participation. I'm sorry.
I think that would be something that would be very helpful and probably very enlightening to folks who are not heavily involved in the EMS world. Like you said, folks are starting at paramedic at $14 an hour in a lot of services. If you could see those average pay rates across the bands, I think that would open a lot of eyes, because I think people assume that the pay rates are much higher than what they are. And if we could get that information out there and do a statewide survey of that, I think that would be helpful.
Yes, sir.
With regard to that. The other thing, and it's really probably more specific to license, the Class 1 licenses, but you talked about the service models over on page 5 of the presentation in that slide across the entire marketplace. But could you get us something that breaks those service models down based on the actual class types as well on that?
As to,
And
I'm
I
not
think-
sure I understand your question.
So, and we've got 2 slides per page, so it would be the slide on service models, the graph that you have.
Let me get back here. Okay, right here.
Could you do a breakdown of that within the class types? And I think Class 1 is where it would really be a focus, because that's where you have most of your services anyway. You've got the bulk of the people that you license there anyway. And so if you could break that down a little better within that class, I think that would be helpful likely.
And Mr. Sloan, I think what Representative Meredith is asking will fit into that matrix of the question I just asked you earlier. So that would fit, nicely into what his question is in terms of having that matrix with all those classifications.
We will certainly attempt to pull that.
Great,
pull that
thank
in.
you. Go ahead, Representative Meredith.
And then I'd like to say I really appreciate you showing the affiliation versus the licensing number, because that's something that many of us have talked about leading up to this task force and in the prior year as we were working on all the different legislation, because we've kept hearing over and over again that we have more licensed EMTs and more licensed paramedics than we ever have. But folks have been wondering how many of those people are actually affiliated with a service and working in the field right now. And so I think those numbers are very, very valuable. I appreciate you bringing those with you today. I noticed a huge hole in the paramedic course programs in South Central Kentucky. If you look at the areas between, say, Breckinridge County down to Allen County, east to Madison or west to Madisonville, and east of there is east, kind of centered around Bowling Green and 3 or 4 counties out. There's a huge hole in that in the map. And then the other question that I'd have, and anybody that knows how I have followed this over the years, do you all have any data on pass-fail of folks who go through an EMT class, pass the actual class assessment, and then don't pass the national registry?
Broken down to that level, I really cannot tell you. I would just have to ask that question and get back to you. I don't know what all they can pull from the data.
If you could get that, I think that could be helpful too. I know that's something that I have harped on for many, many years. We didn't have a national registry test requirement for years and years, and then that became a requirement for the EMT program. And I just wonder what the effect of that is based on pass-fail. Folks who can get out of an EMT class and then just can't pass that national registry exam.
Sure.
Because at the end of the day, in this field, it's not about what you can pass on a test. It's what you can do in the field when you're trying to serve that patient.
Yeah, I know we can pull the registry numbers. I'll see if we can pull the other. Absolutely.
Thank you very much.
Thank you, sir. Senator Givens, you have the floor.
Thank you, Mr. Chair. And Director Sloan, thanks for the information in the slides and what you've put together, your staff's put together. This is exactly what we needed to start the conversation. So thank you very much for what you've provided us here today. Following Representative Meredith's question, very briefly, I'm going to run through a series of questions, if I could, Mr.
Yes,
Chair.
sir.
What's the throttle on the pay question? What's the payer mix? Private insurance, Medicare, Medicaid, other? What's the payer mix?
That for the state, I can't tell you. It's very diverse from one locality to the other. I don't know. Again, I assure you, there's a room full of people that probably know many of these numbers better than I do, but I can't tell you statewide as to the.
Am I missing any of the players? There would be an individual paying potentially,
Yes.
insurance companies, private insurance companies
Yes.
paying, Medicare, Medicaid paying.
That's pretty. You've commercial
That's-
insurance, and that's.
That's about it, isn't it?
That's about it.
Okay. Early in the slide, you had your Class 1. and your other classes. Class 1 was the only one that I saw the bullet on related to CON. Are there other CON restrictions
Yes.
on other classes?
Yes, the only class that we issue a license for that does not require a CON is Class 7, which would be aeromedical. So flight does not require a CON.
All except for Class 7.
That's correct.
So Class 7 is going to be marked as a non-CON. Everything else is going to be CON.
Yes, sir.
All right. The level of information, this is a K-beam sort of question. The information that K-beams collects as it relates to certification, relicensure, what level of detail, and I'm curious about quality metrics, quality measures, runtime, response rate, that sort of detailed level of information. Does K-beams collect that? Is it provided, or how does that work?
Yes, so it's provided as part of the data sharing that so each month, or actually it's less than each month, but as a run is completed, it's synchronized and it comes up and it enters into a data sharing. There's a whole lot of good terms for it that I can't tell you, but yes, we're able to pull those numbers out and tell you what the average response time is and the number of runs per break those runs down, the metrics pretty good.
So K-beam is going to be the repository for that information, and then we've got the cabinet doing the CON process, correct? Is K-beam, what's the K-beam's role in the CON process?
K-beam's role is null in the CON process.
That's what I expected.
All you do is if you're applying for a license today and you bring me a CON and I see the CON and it says for Franklin County, I'm going to issue a license for Franklin County once you meet once you show me that you've got equipment, personnel, and you've met those, I'm going to issue a license.
Okay. As far as the link between the cabinet issuing the CON and or renewing the CON and K-beams collecting information, is there data share between the two? And my question is along these lines. If a region is underserved, I would think the quality metrics that you collect would be an indicator in an underserved region. Is there data share there or not?
I think that would be best answered by the OIG. If the information, no, to my knowledge, again, I want to give the carve out here that I've been doing this for a brief time in this role, and but as I understand it, on the CON process, if someone were to oppose the CON, they could come get that data. But there's not, to my knowledge, there's no sharing of information without a request. Okay. So it would be available if requested, but there's no interface.
Two last quick questions. Out-of-state licenses for paramedics, are they recognized? Is an out-of-state licensure process for a Kentucky paramedic and accepted through regulation licensure or not?
Would you repeat your question one time?
If we have a paramedic that's licensed in Tennessee, can they work in Kentucky under that license?
No, they cannot, but they can apply for a Kentucky license and would with few exceptions, would have little difficulty in getting a Kentucky license, but their license is good in one area.
Okay.
So if they were to come to mutual aid or do something like that, then that license would be good if you were on the Kentucky-Tennessee line. But if I were in Nashville, Tennessee today and I wanted to go work in Lexington, Kentucky, I would have to obtain a Kentucky license to work for a Kentucky licensed service.
Very good. Last quick thought. When you go to work tomorrow, you're back at the office and your colleagues say, Director, how did it go? What's going to be the one key takeaway that you'd like for us to leave this meeting having heard you say?
Well, I think really not so much of what I said, but what I'm getting ready to say is that there's an openness to enter this process with an open mind and be willing to work on the problems and identify the problems. But I guess coming from it is that you're at least interested enough to drill down on the information and figure out where the problems are, as opposed to maybe your hometown, but looking at it across the entire state, that I think that you recognize this is a very broad problem that's not to a particular region.
Good. Thank you. Thank you, Chair.
Thank you, Senator Givens. I want to just follow up on his line of questioning, and we got two more questions beginning to shift gears to our next presenter. When it comes to the CON and the notice, you mentioned in your presentation that there's really, you just get a notice of somebody's going to stop providing service. Is there a tie or is there a follow-up from that action versus why the CON was initially issued? Or what was, is there any tie with that? I mean, if somebody goes to the CON and all of a sudden they say, I've had it, I'm gone. Could you, is there any?
You mean once they've been licensed? So they brought the CON, we've licensed them, they're working now. Is that your?
Right,
and
right.
now they've decided to surrender their license.
Yep.
Do we provide feedback to the CON process as to why we think this agency failed? Or
Yeah, that or what? Yeah, what happened?
No, no.
All right, Representative Hart.
Thank you, Mr. Chairman. Mr. Sloan, and this might be directed, or this is directed towards you and maybe our staff. These are some suggestions. Listen to the presentation and the questioning. You know, workforce is our overall issue that could, if we could better our workforce and get more boots on the ground, so to speak, we can solve quite a few of these problems. But I think some data that would be very useful for this task force as we move forward in regards to the workforce. And do you all have any, can we get a comparison of, rural versus urban service areas and what, a comparison of what the different departments, how their salaries, their benefits, and their pay and stuff like that pan out? And what I'm referring to is, in my EMS career, I worked for the city of Lexington, and I also worked part-time back home where I lived in Pendleton County, which was a rural area. And what made me think of this, I worked 31 years in Pendleton County with no benefits. But it was a part-time job. It was a way for me to serve my community. Was more than happy to do it just for a paycheck. But when we talk about workforce recruitment efforts, that can have a big bearing on getting people to come into the profession. We've already got low pay, but if you're not going to get good or decent benefits or no benefits at all, that's going to be another deterrent. And I'm just wondering, for obvious reasons like bigger tax bases and stuff like that, your urban areas are going to be able to provide more benefits, more security for a job and a career position. But one of the things the committee needs to probably look at as we continue these discussions over the months is in our rural areas, in our really underserved areas, we might have to figure out a way to maybe come up with an idea to get some funding out there to where these rural areas that are really struggling, to give them some help to make a better benefits package. Is that something that you might be able to help us do? Or
Well, first, I would agree that you're right on the funding. I think that's really important that the funding is, or reimbursement, right? Be really clear. This people do a really good job, but they are restricted to this kind of way insurance works, right? You send them a bill for whatever you want. They send you what they want you to have.
Well, and I'm glad you mentioned reimbursement because one of my other question or that I wanted to mention too that I'd like to see if we might not be able to really get this data because it might be hard to get.
I want to go back and if I could answer that.
Go ahead. Go the first.
Yeah,
one.
let me answer. So I don't think that I think you're right. That'd be really helpful to have and really important to have, and is key to moving some of this forward. I don't think K-Beams is the agency to pull that data. We simply that's a pretty large undertaking, and we don't have the staff or at this time to do so. And
Okay.
I don't see that us being at that point in the near future.
Okay.
Because that's a really large task.
Well, and I
as
realize
beneficial
that.
as it may be.
I realize that. You mentioned reimbursement. The other thing, or the other data I think would be very helpful for the committee is if we could get a comparison or a survey or some data that reflects what agencies do hard billing versus what agencies do soft billing, and maybe get a presentation to the committee that explains the difference between the two, because that has a bearing on some agencies have and it's really it's really a balancing act, because I know some agencies have done hard billing and they've been really successful, but I know other agencies, they went to soft billing because they wasn't too successful with the hard billing because it was costing too much for the resources to do that. Is that something that K-Beams could help us with?
I think that we could put together with this task force, put together a survey and certainly use our mailing process to put that out. What do I know that we would get in return? I'm not certain, but I think if in good faith, and I think that this committee is in good faith, that if services saw that there was maybe some help coming, then that would be the carrot to increase participation in the survey.
Yeah, well, thank you. If we could work on that, and
Absolutely.
that'd be great. Thank you so much.
Thank you, Representative Hart. Last question, a follow-up question, Representative Meredith.
One more quick follow-up on your providers working slide. And I don't think this would be a big issue with EMTs, but with regard to the paramedics, with the policy of paramedics working in ERs now, is there any data that shows how many of those paramedics that are not affiliated with a service that you all regulate that are licensed would be working in a hospital facility through an ER?
While I could be wrong, I know of no way, and I'll certainly look into that. But to the best of my knowledge, we do not pull that from the data we have. I could be wrong, but I will follow up.
I think that being a relatively new thing could be something that if we had that data, we could at least assess what's going on.
All right, Senator Givens, let's slide a question. Go ahead, sir.
I had to beg the chairman for one more, and I apologize for that. In listening to your presentation, you said your tone indicated something a little insightful. On the service region slide, you were talking about inspections and the process that K-Beams does for inspections. And I sensed in your statement, and I wrote it down, related to regulations, you said, one size fits all for a pretty diverse state. I want to scratch on that statement just a little. I sense maybe there's something there that you might have some insight for us.
I don't know this specific, but I think it's reasonable to say that as we, if you think about, let's use Harlan, okay? So we go to Harlan and we think about the northern Kentucky area. Well, the equipment would be the same in Harlan that the equipment would be in Covington. Our manning would be the same in one area that it would be in the other. When we begin to look at the expenses just in diesel fuel or whatever the case may be, or equipment that may be needed, but if we're in Covington, they've got a really great and robust dispatch center, and they're able to shift those trucks around just like they do at the airport up there, right? They can get those ambulances moving. But we're trying to make that same model fit sometimes in Harlan that doesn't have the option to call 4 or 5 different agencies that are just a couple miles down the road. So yes, I do think that as we look at, I don't have specific, but I think a one size fit all sometimes may be the only choice, but it certainly makes it tougher. If like one agency may have the ability to have 20 ambulances, all 20 of them have to be stocked to the same level that an agency that only has 2. And even though they only maybe use 10 at a time, but that's the way the regulations are currently written.
You're welcome. Yeah, Director Sloan, thank you very much for coming. I know you have a lot of bit of some homework to do. Just bear in mind that Senator Givens and I and the staff will be there to help you out if you need to pull some information out and so forth.
Yes, sir. So I do have the question that
Yes,
going forward, who should I email? Hopefully that also kept a list of the questions that homework that I've been given, because some of my okay, that's what I will do, because I'm not sure I was quick enough to write all the questions down. But
Do you have
thank you.
Deanne's address?
Yes,
Okay.
I will be in contact. Thank you.
I should have said that. Okay, thank you. Thank you very much. I'd like to have the Inspector General Mather come up. Thank you very much for being patient, and I want to let him know that we appreciate his involvement toward the at the end of House Bill 77, provide valuable insight on what's going on in the cabinet. And with that, sir, if you don't mind, go ahead and introduce yourself and please proceed. It should be available. Use your escape key. Then throw the computer against the wall. It should be at the bottom. There you go. Inspector General, sorry, for some reason we're not picking you up. Do you have a green light?
Oh, there. I'm sorry. It looked like it was the angle, so
All right,
I apologize.
Can you start over
yeah.
again? No, I'm just kidding.
I feel like I'm at my bar mitzvah again. Yeah. All right.
Go ahead, sir.
So, all right, and then I apologize about that. And then the last one is quality of services, appropriate care consistent with appropriate standards of care overall. And so that criteria is established by KRS 216B 040 subsection 2A, and then the decision is rendered typically by the cabinet within approximately 6 to 9 months is more accurate, I think, with that statement. And then non-substantive review, or non-sub review as it's commonly referred to, is an expedited process for projects with no established criteria in the state health plan. And then an affected party can pursue contesting a CON application, non-sub review. It's typically an easier pathway for CON approval, and there is the presumption that there is need unless rebutted by clear and convincing evidence by the affected party. The formal review process obviously has a much higher burden to prove. And then, so we'll go into how House Bill 777 impacts CHFS and CON in particular. So House Bill 777 requires the Cabinet for Health and Family Services in our office to investigate and hold hearings regarding complaints related to ambulance services, but leaves a disciplinary action for the Professional Licensing Board of K-Beams to those individuals that are licensed under them. And then it also reforms the CON requirements for ambulance services owned by cities, counties, and hospitals. And ground ambulance applications that do not qualify for CON exemption or non-sub review status are granted. House Bill 77 will remain in effect, subject for formal review. And so basically what that means is if you're a new ambulance service wanting to come into the state, you're still going to have to go through that formal review process, like the typical level 1 ambulance service. Or if you're an existing service within the state and you want a new catchment area, you would still go through that formal process. And then the exemptions, 777 retains the current CON exemption for city-owned ambulance services that provide transportation in coterminous city outside of its service area if the governing body of the coterminous city enters into the agreement with city-owned ambulance providers. What that means in layman's terms is, like, let's take Louisville, for example, Representative Fleming. So all those Hurstbourne and all those little areas, they count in that area, and so that allows them to stay within that catchment area. I think I miss. And there's no sunset provision on that existing exemption. And then House Bill 777 creates a new CON exemption for hospital-owned ambulances services that provide non-emergency or emergency transport originating from the hospital. And so that would be hospital-to-hospital transfers as well as non-emergency transfers from the hospital. And that provision does sunset on 7/1 of 2026. And then it allows hospital-owned ambulance services exemption from CON in accordance with KRS 216B.020, subsection 7. They can provide transportation from another health facility to a hospital without need for CON approval if authorized by the ambulance provider in the service area. And so what that means is that I think maybe on the next slide here, that authorization requires that the hospital contact at least one ambulance provider within their catchment area to see if they can make the run. If they can't do it within a 4-hour period, then they are allowed to go ahead and make that run. And it creates a new CON exemption for cities or counties seeking to provide emergency ambulance transport services under the following conditions. The city or county government has conducted a public hearing to demonstrate that an imperative need exists to provide emergency transport within its jurisdictional boundaries, and the city or county will directly provide emergency transport within its jurisdictional boundaries, or enter into a contract with a hospital located within its jurisdiction or in an adjacent county if there is no hospital in this county. And that sunsets as well on 7/1/2026. I think the provision is that we have to, once they notify our office, we notify every city in the state and let them know that that's happening if they'd like to be an affected party. And then it grants non-sub review status to city or county-owned ambulance providers that seek to provide 911 transports and hospitals that seek to provide ambulance transports from a location that is not a health facility. Non-substantive review status granted by KRS sunsets on 7/1/2026. The exception is, I think Eddie mentioned it, the industrial ambulances like Corning, I think, had one. There are, I think, 11 or so in the state. And then the related regulations, so the state health plan, obviously, which kind of gives us our guidance for what is required in CON and not in CON. And then the certificate of need non-sub review criteria was amended as well to align with House Bill 777. And I open it up for comments. Not very exciting stuff.
Well, I tell you what, it's when I first got into it, it's rather complex. The more time,
very
you get
technical.
the more you get into it, sometimes you get a little more confused. But then again, I appreciate you going through and give a little more definition, understanding on how the process works. It provides a little more clarity, and I guess it's just more of a. Because speaking of clarity, EMS jurisdiction, is that defined in CON or?
It is, and then the catchment area itself is very specific. Like they have to give it; it's down to the street. So when they send in that application.
Okay, alrighty. Is there any questions from the committee? No, we got one. Senator Givens.
Sure, thank you, and Inspector Mather, thank you for being here. Thanks for your presentation. So back up to slide number 3, which is your what is formal review slide. Your second bullet indicates rather clearly the applicant bears the burden of showing that the proposed health service meets all 5 review criteria established by statute, including consistency with the state health plan. As the cabinet, does this process of CON fall to you, the Inspector General? Who does it fall to in the cabinet?
The Administrative Hearings Office.
Administrative Hearings
Hearing
Office.
Officer,
Okay. And so for a layperson, walk me through what happens when a CON formal review process occurs.
Okay, and if I miss a step, Kara will correct me, because there's some batching cycles and all this stuff that
Sure.
goes through. So someone puts in an application for a CON, goes to our office, we will deem it as complete once it's all criteria are met. We send them that notification, then it goes into our newsletter. where everyone has access to it that's in healthcare. And it's shown when the batching cycle will be for that, when the next batching cycle will be for that particular CON application. Then affected parties have the opportunity to go to our office to say they're an affected party. That if there was no affected party, there wouldn't be a hearing. If there is an affected party, then it goes to a hearing officer. Both sides present their case as to why one, obviously the side that wants the CON shows why they are deserving of it and meet those criteria, and that's really what it's about, is meeting those criteria. And then the affected party would obviously provide evidence that would show that they were not needed in that catchment area. And then the administrative hearing officer, once they get additional documents from the two sides, would come up with their findings.
So this slide, and then one of the bullets on the second slide, the next slide, non-sub review. Non-sub review generally offers a smoother pathway to CON approval. The presumption of need is, we start in non-sub review that the presumption of the need is there.
Correct.
Go back to the formal.
You have to prove it in the formal.
It's the opposite, isn't it?
Correct.
Okay. So in proving it, when you say criteria met and hearing officer involved, if there is someone who shows cause that it shouldn't be approved, those criteria, are they spelled out in statute or in regs?
They are spelled out in reg, right? In statute. I'm sorry, in statute. Yeah, based on our. Go ahead.
The 5 criteria are they're in statute in 216B040, but it does, one of those criteria is consistency with the state health plan, and the state health plan, the contents of the state health plan are in regulation.
So I've actually got that pulled up here on my phone real quick. So 2A is consistency with plans, 2B is need and accessibility, interrelationships and linkages, cost, economic feasibility, and resources availability, quality of services, hospital-based skilled nursing, that's F. Again, layperson here, so help me understand. Is there a score sheet that someone sits down with the hearing officer or someone and says you scored this many points here, this many here? How does it work? How do we deem it yes or deem it no?
So some things are more definitive than others based on an annual survey that we do to show the need in the communities, and others are not as clearly defined. It's based on the level of care that's being delivered.
So we've got a process that's both objective and subjective. Is that
correct? Yes.
Sort of what I'd hear you say?
Yes.
So in specificity for purposes of what we're working on here, when we know K-Beams has information and numbers about run times and quality of service and response rates, logic says it would be good to have that woven into the conversation about CON and whether or not adequate service is provided in the area. Is that up to the entity that's making the application to say, look, we want to show you that current service is inadequate, or how does that work?
Yes, it would be their burden to prove it.
Okay. All right, thank you.
Any other questions from the committee? All right. Inspector General, I just want to follow up. Ask Mr. Stone the question in terms of the notice. Do you know of any any process or anything that occurs when a notice is given that somebody wants not to provide service even though they've gone through the CON?
So the CON is the easiest way it was explained to me is it's kind of your ticket for admission. So once we give that CON, we're kind of out of that. That CON goes away. It then becomes, once you get admitted, you now have a license. And so, so we don't have any, because we don't oversee that licensure category. So we don't have any knowledge of if they are going out of business or not.
Okay. Got it. I understand that. Okay. Yeah. Go ahead, Senator.
Thank you, Co-Chair, and I apologize again. So this concept that informal, in the formal review, the applicant bears the burden, but in the non-sub, it's a presumption of yes. Is that something that's found in statute? Where is that found in statute?
The non-sub, and I will say
specific to the formal review.
Well, is it not in the same?
I'm trying to remember how much of it is in regulation and how much of it is in statute. I do know, I was looking at the non-sub statute this morning, and I do know that the statute sets some things subject to non-sub, and then it also gives the cabinet
Could you,
discretion.
I'm sorry.
I'm sorry.
Are you, is it green?
It is.
It is green.
Okay, I was
It
going to
is
say, are you
I'm-
green? I was
I'm
like, that
just-
didn't come out, I want to come
Yeah.
out right.
I'm just very quiet.
Thank you.
So the statute there's a statute that establishes some things that are subject to non-sub, and then it also gives the cabinet discretion to add some other categories to the non-sub review process. I do not immediately off the top of my head remember which the burden of proof, how much of that is in reg and how much of it is in statute, but we can certainly get that to you.
Get that for me if you would, please. Thank you.
And I just want to sort of dovetail on the senator's request. It goes back to my gearhead approach. Is that possible to have a flow chart between the statutes and the regs on how this goes through? That would be another visual for me to have
So
a clear
from
understanding.
from like thinking about submitting an application to receiving your CON.
Yes, sir.
Okay.
Thank you very much. I appreciate that. Yes, ma'am. Go ahead, Representative Wilner.
Thank you, Mr. Chairman. Thank you for the presentation. I'm just curious to know if this system is working or if you see problems with the system as it currently exists.
It is a very contentious topic. I will put it that way. Yeah. We have very talented people that work in that office, and they work very closely. I think anybody that you talk to that has put in an application would speak very highly of those individuals and how helpful they are. I think I don't want perfection to be the enemy of good. So it is a system that certainly works in the state of Kentucky. You got it.
And I just want to follow up. Do you can you shed any light, and we might have some folks come in down the road in terms of what other states, how they treat the CON when it comes in ambulances?
So we are one of only, I think, 2 or 3 states that actually have CON attached to ambulance service providers.
Okay. Okay. Well, we're I guess but part of the process we'll probably bring some people in that'll have that. I guess the National Conference of State Legislators or some association will come and provide that information. That'll be helpful. So, but good. Is there any other questions for the task force? Okay. Thank you very much.
Thank you.
Appreciate your time. All right. I think it's been very productive. I hope y'all have gotten a good understanding and at least a foundation on the certificate of need process, as well as what's going on with K-beams and so forth. So, and I just want to make sure if there's things that you all, the stakeholders have, you observed or thought, please let us know based on this committee, based on our conversations we've had today. We're here. We're all ears. We're trying, like I said, we're trying to get the best system possible. Make some modifications or whatever we might do with it. So, so anyway, I think we'll go on from there. And I believe the next meeting will be chaired by Co-Chairman Givens, and be on the 16th of August at 3 o'clock, and I believe in the same room. Is that right? Okay. Okay. Without anything else, we stand